Good morning. I'm not by nature tethered very well, so I'll do my best to use the microphone. And I apologize if I wander. So, yay, the clicker works. So I'm going to talk today about creating a culture of concordance. I work at a large integrated hospital system across 5 states, but my area of influence, we all have our area of influence. My area of influence is 4 hospitals in eastern Washington, 2 critical access hospitals up near the Canadian border. So we're on the eastern side of the state, the dry side of the state without traffic, beautiful lakes and rivers and all that. So the nice side of Washington, we like to call it, rather than the wet side, populated side, traffic side, where Laura and Jessica live. In addition to our little critical access hospitals, the hospital where I live most of my time is about a 600-bed level 2 trauma center. And then in our same Spokane community, we have about a 200-bed community hospital. So that's where I look for concordance and create this culture of concordance. So my objectives today are, who do we partner with? Because none of this work can be done by ourselves. Who do we partner with to create this culture where we can provide concordant care? What strategies do we use to identify legal surrogate, and then how do we communicate with that legal surrogate? And then how do I measure concordance? How do I look for that evidence? So why do we bother with concordance? Well, why do we bother with any of the rest of this if we don't offer concordant care? So we can't do any of this work without having the confidence that if you tell us what's important to you, that's the care you'll receive. So there's a big push in my hospital system for what they call shared decision-making and whole person care. Those are squishy terms, as Dr. Sidori identified. We don't have good national agreement on what those things mean, so I kind of hijack those and I use my own definitions for what does this mean. Shared decision-making is engaging those people whose lives are affected by the decision, and value-centered, patient-centered care, person-centered care is how we deliver that. So we must have confidence that that patient and family voice is heard. And we recognize that when patients are informed in their choices, fewer interventions are requested. Fewer interventions are requested. So as our population needs, we anticipate them going up as our age goes up. We anticipate that if left unchecked, those resources required also will accelerate. And our aim is to provide instead care people want and avoid care they don't want. So as I look to find that happy fallow ground for concordant care, I start with our mission. So we are a Catholic hospital system, and our mission is to be an expression of God's healing love, witnessed through the ministry of Jesus. We are steadfast in serving all, especially the poor and vulnerable. So who are the poor and vulnerable that we see? Are they the patients without capacity, the voiceless at the end of their life? So how do we advocate for the poor and vulnerable among us? Another place where I have found a good partnership in pursuing concordant care is in our work as an institution, as an organization, in being highly reliable. All these patient safety-centered initiatives blend themselves beautifully to this issue of concordant care, that patient-centered care belongs at the center, that patients' wishes must be honored, and if indeed they're not honored, that's a patient safety issue. That is a medical mistake akin to prescribing and delivering a medication to which a patient is allergic. So aligning this initiative where we have lots of system emphasis and support and payment, support staff-wise, education-wise, training-wise, time on almost every meeting agenda at the start of a meeting, talking about a patient safety story. How many patient safety stories could you introduce and use that very rich patient story model that's captured our hearts during this conference time and again? by illustrating those instances where things went sideways. And then you can elicit that commitment to, we can do it better. We can do it better. So we've also recognized this week that nothing happens without leadership support. So obviously I like this dress because I wore it in that picture too. But this picture includes my boss's boss, and my boss's boss's boss. So up to the senior leadership level that governs all of Washington and Western Montana. It also includes our medical director for ethics, who is one of my favorite partners in this work, Dr. Andy Chatburn. She and I take our dog and pony show on the road. So now I've kind of shown you who I collaborate with, who we collaborate with, because this is a shared vision in that culture of concordance. So now, how do we make sure that we begin to provide concordant care? We start with education. So with my partners in ethics and risk management, we take our dog and pony show on the road, and we talk to nurses, we talk to social workers, we talk to the folks in patient access who in our organization are tasked with asking that Joint Commission required question, do you have an advance directive? And then they used to go on to say, who is your emergency contact? And they would get their neighbor who was going to drive them home today. Instead, this fabulous group of staff who are so amenable to scripting, they changed that question, and instead now they ask, who is your emergency decision maker? And they get a very different answer. And they know what our hierarchy is. So if the patient says, no, I don't have an advance directive, I don't have a power of attorney for healthcare, but my emergency decision maker is my neighbor, Mary, they know Mary's not on the hierarchy. And so they're able to provide that just-in-time education and motivation. If you want Mary to be your decision maker, that's great. Here's the document that you need to complete. We'll help you complete that so that Mary can be your decision maker should something happen at any time in the future. And not only that, we'll keep it in our medical record so it's available to you. So patient access, what a simple way to ask a different question and get the answer that we really want. Our hospitalists and intensivists. So the provider nut is a different nut to crack, isn't it? And so often we recognized earlier too that providers learn best from other providers, which is why I bring my partner, Dr. Andy Chatburn, rather than nurse Kellie Durgan, right? So it's that different level of communication and respect. Unfortunately, we live in a very segmented healthcare society. Even in the operating room where I lived for many years, anesthesia and surgeons, right? It's all these different layers. So how do we make those layers work for us? So what I am finding now after 3+ years is that our hospitalists and intensivists are recognizing that, one, they didn't want to have these conversations because they belong in primary care. So we're doing them in primary care. But now they're willing to pick up those fragments of those conversations that they find evidence of and carry it further, not only in a code status discussion, but gosh, things are changing. Things are changing, and let's talk about what care really suits you best. What do we have right now that can benefit you in the intervention option? I heard earlier this week about we diagnose, we offer options, but not only what can we do, should we do. So I hear more and more about what ought we provide for you, what provides benefit, and what trade-offs do you have to live with in order to receive that potential benefit. So their conversations are changing and their documentation of that is changing. So we rely on our medical record to find documents, so we educate on how we find documents by leading them to our one-stop shop, that we have an epic that indicates, do we have in the big orange tile, is there a POLST form, yes or no? Is there an advance directive in the blue tile, yes or no? What was their code status? What is their current code status? Has it changed? And then in the last tile, are there any advanced care planning notes or goals of care notes in this patient's chart? And it will link them in a list so that they can just click into that smart phrase and see what that documentation of that last conversation looks like. So it brings all the information in one place. They click on Pulsed in the banner, they get this page. So it's not 14 clicks that just frustrates everybody. We also leave some tools behind. So this little infographic is laminated on every nurse's station in our 4-hospital system. It provides that first question of capacity. Does my patient have the capacity to make their own decisions? So we all assess for capacity. It identifies, yes, if they do, then you go for it, keep running. If the answer is no, how do we identify that legal surrogate? And if we don't know, what partner do we lean on to do that formal capacity assessment at this moment in time, recognizing that capacity waxes and wanes, and capacity is decision specific. So my patient that I get called for often to have a power of attorney conversation with can tell me who they trust, but they can't decide amongst their complex discharge options where they can be discharged. They want to go home. They really want to go home. And they recognize it's probably not safe and they should go someplace else. So those capacity issues can be complicated. So we lean on our providers to do that assessment. Further down in this little capacity tool, it identifies if you have documents, your documents can either lead us to a state-appointed guardian, which we don't get very often, but way too often actually for those isolated people that we have, or the power of attorney for healthcare. But in absence of documents, it leads us down our Washington State, you guys have heard that a lot, I apologize. Our hierarchy, starting with legally married spouse. So that significant other, while very devoted and obviously invested and using that substituted voice, still has no legal power unless they've been named as power of attorney for healthcare. In our state, it is, there is no majority rules. They must come to consensus. So the largest care conference I've been to, this woman had 16 children. We had 8 present in the room, about 6 on the phone, and a few said no thank you. And surprise, surprise, they did not come to consensus. And the outcome for this woman was not what most of her family wanted for her. And yet that's what we were held to. Our state hierarchy ends at siblings, so nowhere on this list is the person who knows me best, or nephew, niece, grandchild. So we are lobbying our state legislature to add that at that bottom of our hierarchy so that it frees us up when there is someone who is interested and willing to advocate, that we can utilize this person rather than going to the courts and having a guardian name. We have done a load of education in how do we assess for capacity. It is amazing to me how many of our attending providers don't feel comfortable in that capacity assessment. So we walk them through, how do you assess capacity? Do they understand the subject at hand? Do they recognize they have choices? Can they indicate which choice that they are picking with some kind of reason, and then have some kind of consistency, ideally, in that goals conversation that we had first, but sometimes over time as well. So, and then how do we document that conversation? So like so many of you, we developed a smart phrase that they can drop in, fill in the wild cards that will clearly identify at this moment in time, the patient did or did not have the capacity to make this decision that we were asking them to make, whether it be surgery, discharge, chemotherapy, or other treatment arms. So it clearly identifies that process of capacity assessment. It also allows other people on the team to identify when there are moments when decisions need to be made. We are going to work to have that legal surrogate available, whether it be before surgery so that the consent can be signed, whether it is in preparation of making a decision for something like a feeding tube. How do we identify who that legal surrogate is? So we encourage them to write their name and their phone number on the whiteboard so that the provider walks in, you see this person in the room, and oftentimes our attendings, they just start talking, right? We don't know who that person is. It could be their neighbor, it could be their husband, but we don't know that because we don't ask, right? What I often also see in, although we are increasing our frequency of clearly documenting care conferences and goals discussions, I still often see that documentation goes something like this. Tell me if you've seen this. Condition updated with family. Prognosis continues to be poor. Family comes to consensus to move to comfort-focused care. So, was the legal surrogate there? I don't know. I hope so. Family. What kind of information, what did that shared decision-making conversation look like? I don't know. It appears that that information that was relayed painted this picture of this poor prognosis. What does poor prognosis mean to the clinician? What does poor prognosis mean to the family? It's like when families say, well, I want you to do everything. Well, their picture of everything might be this. Well, what's our picture of everything? This is everything. They don't even imagine what everything could be because this is our everyday world and not theirs. So that's some of the coaching that we're doing. So now I'm going to move to how do we measure concordance in our organization. So I do a chart audit every quarter. I look at patients who die in our 4 hospitals. I look at about 20% of those charts. So I look at about 55 or 60 charts every quarter. I look at what documents did we have? When were they signed? When were they scanned to the medical record? So when did they come into evidence for us to include in decision making? And what did they say? What interventions? I only look at that terminal hospitalization. What interventions did that person receive in that last hospitalization that we might consider to be life-sustaining? Dialysis, CRRT, were they intubated? Did they have a code attempt done? What was their length of stay? Honestly, in a longer length of stay, we have more opportunities to provide discordant care because they're here. And things go sideways amazingly quick sometimes. What was their age, sex? I look at the unit where they died because of the research that we see about families suffering from dysfunctional grief or PTSD for patients who die in the ICU. So do we make efforts once the decision is made to change the focus of care to get them to a more appropriate room that is more conducive to just being present, or in fact go to a hospice house or some other opportunity? What was their diagnosis? Often I feel when patients have end-stage disease and no documents, we've failed. Did they receive a palliative care consult? Is there some kind of documented care conference or goals of care conference? What I see is about 60% of the time, patients have some kind of ACP documents. So these are patients who die, right? But sometimes they die unexpectedly, tragic results. So this is over the last 6 quarters. I've been doing these charts for about 3 years. About 60% of the time, we have some kind of documents. Death occurs outside of the ICU, on average about 60% of the time. And most of the time, care in that last day matches known wishes. So I emphasize known wishes. How do we measure concordant care when we have no documents? We can't really do that. And so for 40% of the patients that we take care of during their last hospitalization, my answer has to be, I don't know if they received concordant care because we have no documentation of what their wishes were. We ideally have some explanation from their families, but we also know that that also can go sideways for a variety of reasons. We have clear evidence from our med execs that wishes not followed is a medical error. And our culture is really strong to involve either palliative care or ethics to help us untangle when it's messy, when that way forward really isn't clear. And I am finding more and more support from our intensivists and our hospitalists in clearly documenting their conversations. I can't say clearly. They're documenting that conversations happen. We have room to grow in how clearly they describe those conversations. But very firm support in upstream conversations. So I'm going to end with opportunities to continue. So we're a level 2 trauma center. So patients come to us from about 150-mile radius. And rarely do they come with documents. So somewhere along the way is agreeing to a higher level of care for some reason, but it's not clear if there's any boundaries around that care. So that's one thing that we continue to encourage. When you transfer your patients, send documents that elucidate their goals and values along with them. It's always a time of crisis for this family. We recognize this is a poor time at the time they're landing in our hospital to talk about this. Code in progress from the community. No one goes to Applebee's with their pulse around their neck, right? So what happens when codes get initiated out in the community? And so our task is to make sure once they arrive at our hospitals, what is our process in identifying who they are, what are their documents, and then having a conversation with their families and discerning the best way forward at this time for where we are. So that work continues in our emergency rooms. We still look to care conferences with legal surrogates and work to educate our care team in how do we recognize grief for what it is and treat it as grief with compassion and dignity, and instead elevate that patient voice. What would your mom say if she could talk to us right now, instead of listening to I want, I want, I want. And then again, training our providers. So any questions about this journey? It's a journey that continues, but I am so happy to have partners.
Let's give Kellie a round of applause. That was just a wonderful, inclusive presentation. We're recording this session, so please wait for the microphone.
Thank you for the nice presentation. I have two questions. One is for patients who die outside of the hospital, is there any way we can determine concordance?
So that is a good question, and what I try to see for those patients that come into my view, either through my role on our palliative care team or in other ways, how are we determining that discharge decision? So who are we including in those discussions around home health or hospice house? My sense is that our providers, if they feel uncomfortable about that discharge plan, they're calling ethics. So I wear an ethics hat too, so we're getting pulled in with those and helping to tease that out. My sense is we're doing okay. Is it something I measure? I do not.
Okay. And the second one is patients who get discharged from the hospital, let's say, on home hospice.
Yes.
So if that's what their goal was, to not get aggressive care in the hospital and go home and die peacefully, so we're discharging them with hospice, should we taking them into account, saying that yes, we provided concordant care?
Absolutely. It's more difficult to measure in how do we have those charts be elevated for review, to really get that sense of counting numbers. And I suppose that we could work with those folks who work with us in discharge planning to feel confident that that is the direction that things are going. Another thing that we do look at, though, for those patients who are on hospice who return to our emergency room, how do we manage those patients differently from anybody else landing in our emergency room looking for acute care? Do we track them differently? Do we treat them differently? How do we get them back to the care that they once thought was most appropriate, making sure that they still believe that's most appropriate? Because people change their minds sometimes, especially in crisis. Great questions, thank you. Food for more chart audits in the future.
Kellie, you're doing fabulous work, and I'm actually kind of jealous because this is the work I really love to do and obviously don't do anymore. Second of all, I want to give a shout out to Epic, because the things that you're doing in Epic are now possible to do,
Yes.
and it makes a huge difference.
Yes, I couldn't do this without Epic, honestly. Yeah. Yeah, our own bastard stepchild of Epic that Providence uses.
The medical record really is the hub in honoring, because without the ability to push that information forward in time and maybe across settings, we can't accomplish anything.
Right.
But here's just a consideration. One of the things that really, I think, pushed us ahead at Gunderson was the peer review committee looking at hospital deaths and looking for quality of care or errors.
Right.
Always looked at whether did the patient have any type of written documentation of their preferences, and was it appropriately used by the treating physician making decisions. And when they found discrepancies, when they found discrepancies or what appeared to be discrepancies, they followed up to say, was a mistake really made here? And if so, why? And if it really was a physician who was disregarding preferences, that was a serious medical problem that needed attention. So it was a way of creating accountability for the mission that you have. And I don't know if that's been thought of, or it's not something I was able to create on my own. This was after years of physician culture change where the physicians came to this perspective themselves.
So great point. When I find cases where it's not clear either when a document was brought in and able to be included by the medical team, so, or I wonder, no documentation of a conversation took place. So what I do with those cases when I wonder, gosh, what happened? How did this turn out this way? I put it into our event reporting software, and I hold it up to the gods to look at. Just another layer of eyes to look at this, but that's where it goes. It goes to the medical staff office for peer review, and they look at it too. And I appreciate that oversight, because then they can own how that goes, and they can do education. It's not a stick to beat people with, but it is a way we can educate so that we can do better the next time.
Thanks, Kellie. Really quick question for you. Thank you for the wonderful work. And your measurement of documents in the medical record is wonderful, but my follow-up question to that is not all documents are the same, and we know some documents are more effective than others.
Yes.
So in your concordance reviews, are you finding that the documents themselves are actually helping clinicians to guide clinical care leading to concordance, or are you finding that more often they're not as effective as the clinical notes, or both, or what are your observations about that?
So because we've only been doing good documentation of conversations for about the last 2.5 years, I think that we're much like Dr. Sidori's population, that we started with those healthier folks, and they haven't risen to the point that they're really sick yet. And the most common document that we have in our charts are POLST forms, which are very clear delineations of care choices. About 1/3 of the advanced directives that I look at are those legal generated ones that say, if two physicians find me to be in a persistent vegetative state, blah, 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 that really don't drive care at all outside of identifying a decision maker. They're not as effective, but the most common, we are a very POLST heavy organization, which is why we do advanced steps more recently. And those do an excellent job of identifying not only do I want to be resuscitated, but how aggressive do I want my care to be.
Thank you.